Good evening, everybody, and welcome to our second annual general meeting of the Family Alliance on Severe Mental Illnesses, which we call FASMI for short. My name is Kathleen McNackey, and I have the honor of being the president of FASMI, an organization that seeks to amplify the family voice and is striving to ensure that Canadians living with psychotic illnesses receive timely and effective treatment and rehabilitative supports to achieve the maximum recovery possible. I will now call on Eva Sultan. Acknowledgement. Eva?
Thank you. Good evening, everyone. I will now give the land acknowledgement. We acknowledge that we are gathered on the traditional and unceded territories of the First Nations, Inuit, and Métis people of Canada. We are honored and privileged to work on this land that we all share. We're committed to reconciliation, decolonization, and working with and learning from Indigenous communities throughout Canada. Thank you.
Thank you, Eva. So the meeting will begin with a presentation by Dr. Daniel Vigo. I will now call on our Vice President, Susan Inman, who will introduce Dr. Vigo.
Thank you, Kathy. FASMI is very honored that Dr. Daniel Vigo accepted our invitation to speak to our members about the transformational work he's been doing in British Columbia. Dr. Vigo has been helping more people with severe mental illnesses get the kinds of treatment they need. We have watched as BC families have been inspired in hearing Dr. Vigo say the kinds of things that too many political leaders have been hesitant to acknowledge. And we knew families in other parts of Canada would want to hear from him. After his presentation, Dr. Vigo will respond to questions, including some that were sent in earlier. If you have questions for Dr. Vigo, please put them in the chat box. And if you move your cursor around your screen, the chat box should pop up. And if you click on it, there'll be a long column, and make sure that after you enter your question, you press the arrow to make sure that it is visible. Please understand if we can't get to all of your questions. And please know, as mentioned earlier, that Dr. Vigo's presentation is being recorded, and you will be able to access it on FASMI's website. In fact, we hope that you will share it with other people. Welcome, Dr. Vigo, and over to you.
Thank you very much, Susan, and thanks everyone for the invitation and for being interested in the work that we're doing. I'm going to try to share my screen. So it tells me that sharing is not turned on, so I'm sending a request, and someone
I will allow it.
That's it. Thank you very much. So, are you seeing the?
Yes, there we go.
Yes, we see your slide.
And now the presentation mode, right?
Yes.
Okay, great. Just a second. Okay, so I'm Daniel Vigo. I'm a psychiatrist. I'm also faculty at UBC in psychiatry and public health. And since last June, not actually since June of last year, I've been working as BC's Chief Scientific Advisor for Psychiatry, Toxic Drugs and Concurrent Disorders. And the goal, well, I'm going to say things about my office later, but the idea is to present the work that we've been doing in BC for the past year and almost a year and a half, actually, at this point. I also acknowledge with gratitude that I live and work on the homelands of Musqueam, Squamish, and Tsleil-Waututh nations. And this, I will present some data that is being produced and analyzed by my office in real time. And so the analysis are accurate for sure as of October 31st and even later. but I just want to clarify that this is an ongoing analysis. Though I'm confident in the robustness of the data. And if you may have seen some of this update in other occasions, there is some new details that I have added for this presentation. And I'm going to talk about off-label use of medication, which is the responsibility of the treating physician, and only should be done when the first-line effective alternatives have failed, which is unfortunately the case for many folks with severe mental and substance use disorders, and therefore is frequently very important for us to be able to do that. And my introduction to this, and since there's folks from different areas of Canada, it may be interesting to know how the crisis, quote unquote, mental health crisis, evolved, and how I first heard about it, which was around 2013, when the mayor of Vancouver and the chief of police, interestingly enough, the mayor of Vancouver is now a housing minister federally, and as we will see, some of the main challenges that we have are with housing. And so what they identified way back then was that, and this reverberated at every level of government, and the minister at that point said that we're dealing with something new, something different, permanent brain damage, acquired brain injury from the long-term use of drugs like methamphetamines. And so we already had, way back when, the three main ingredients of the current public health emergency that we're facing here in BC. It's painful to say, but it has been called an emergency almost 10 years ago now, even though it hasn't been treated as an emergency by any reasonable measure. And we had the three ingredients: the mental disorder, the severe mental disorder, the substance use disorder, and the acquired brain injury. And we had, what had motivated this announcement was the first few hundred patients with this form of very severe combination of disorders were in the downtown east side, and were being identified as an issue, a health issue, that the police were saying, we can't deal with that. We shouldn't be asked to deal with this. The healthcare system should take care of this, which unfortunately didn't happen, which is why we went, and I use approximations. You will see what the specific numbers are, but how could we go from 300 in 2013 to around 3,000 in 10 years, and around 30,000 at risk? And I'm going to provide the details. I identify three main drivers of this issue. One is the closure of Riverview Hospital without adequate replacement. And this happened throughout the world.
Not going to bother you?
No.
At different times.
You can join me if you want to.
So there's if folks can mute themselves, because there's some conversations that are being heard. I think, Marguerite, if you can mute yourself, that would be great. Okay, so the closure of Riverview without adequate replacement. And this happened, as I said, throughout the world. The ideal was that we were going to be able to treat people with severe mental illness in the community because of the advances in psychopharmacology and in community mental health. But the truth is that we didn't make the investments that would have been required to do that in beds in the community and in community teams, like assertive community treatment teams. And so what happens was that there was a trans-institutionalization of patients from the mental hospitals to corrections or precarious housing and homelessness. In the US, it's famously to corrections. And here in BC, it's less to corrections, though some of our patients are there, and mostly to homelessness and precarious housing. The main driver, of course, is the technological revolution in the production of cheap synthetic drugs at scale. So these drugs, fentanyl, carfentanil, crystal meth, are nothing like the drugs that we had 20, 30, 100 years ago. opioids existed forever since medicine existed, and it produced a number of global even wars. But these types of drugs are different, and I use a metaphor or rather an analogy with Moore's law. Moore is a guy that said that the power of microchips would double every couple of years, and that took us from the old computers, which were based on perforated cards, to AI now. And the same thing happened with opioids. Fentanyl is 100 times more potent than morphine. Carfentanil is 10,000 times more potent than morphine. Nitazine somewhere in between. And these drugs are being mixed by drug dealers in some shed somewhere or in some place without any knowledge or care about the consequences of what they're doing. And they're put into something that reminds me of what our cardiologist friends wanted to do. They wanted to invent a polypill combining certain drugs to treat all cardiovascular disorders. That didn't happen. But the polypill that the drug dealers create in our communities all have a combination of drugs, so that any person who is unfortunate enough to seek either a stimulant or an opioid or a party drug of sorts, they will get a combination of a little bit of opioid, a little bit of crystal meth, and a little bit of benzodiazepines, which makes the addiction not only immediately harmful for the brain, but also extremely difficult to treat. And finally, and this is more painful because it has to do with how poorly we responded as a discipline and as a health system, which was a siloed evolution of addiction medicine and psychiatry. And again, this was understandable because when the need exploded after the closure of the psychiatric hospitals exposed all of our patients to this emergent market of toxic drugs, there were very few addiction psychiatrists to treat the demand. And so a new discipline was created, addiction medicine, which basically extrapolated what we had learned from infectious diseases, which was that, such as HIV or tuberculosis, which, and some of our researchers here in Canada contributed enormously to the successful curbing of the AIDS epidemic. How? By focusing on getting people to take their drugs, their antiretrovirals, in that case, in a regimented manner, every day, at each time, the combination of drugs. And so they applied that to opioid use disorder. And they said, okay, if you take the methadone or the morphine or the buprenorphine in this specific way every day, you will be treated of your opioid use. And that's fine, but it doesn't work when, in addition of the opioid use disorder, people have a severe mental illness such as schizophrenia, bipolar disorder, etc. Because in that case, only very few patients are able to attach to follow that strict regimen. And since they don't focus at all on their mental illness, in fact, if it's severe, it's an exclusion criteria from most addiction services. The result is that there was a blind spot on people with concurrent disorders, a drift away from evidence-based medical treatment for severe mental illness, and all sorts of social experiments that were tried and failed miserably in our province. One of which was the conflation of medically required involuntary care when a person is unable to exercise their freedoms because of mental impairment. That was conflated with the involuntary treatment of addiction, and advocates managed to really tie our hands in our ability to treat involuntarily patients when needed. That led to an underutilization of the Mental Health Act as a therapeutic tool for people with severe substance use disorders and a growing burden of neurocognitive disorders due to acquired brain injury in people with severe mental illness who were excluded implicitly or explicitly from most addiction services. So this is what led to the picture that we have now, which is that this is administrative data from BC. And this Venn diagram represents people with severe mental illness, with addiction and brain injury. And these are very stringent definitions. And what we see is that we can already detect in electronic medical records around 2,500 people in BC that have the three things. But these are very severe because for some physician to actually diagnose acquired brain injury, that is because it's very bad. And what we're not diagnosing yet, and I will talk about that just now, is the mild to moderate burden of acquired brain injury on top of the severe mental illness and addiction that happens. And that is exactly what we're trying to prevent. We're trying to prevent the drift of people with severe mental illness, with addiction, or both, to acquired brain injury. Why? Because we know this is hotel data. The hotel study is a landmark study here in BC, hotel, and now it's called Tandem, led by Bill Honer and Will Panenka. And they have shown that people in the downtown east side, who they've been following since 2008, have more brain atrophy that control population. They have decreased cognitive function than their peers. And there's a vicious circle between overdose and acquired brain injury. And new data that we were able to produce since my office was created in collaboration with the hotel study, a study led by Saint, because the hotel study made MRI imaging of these patients every 6 months approximately, and some of them had an overdose between those two MRIs. And so what they were able to demonstrate was that if we look at the people who happen to have an overdose between those MRIs and compare it to controls in that same population who did not have an overdose between that MRI, we can ascertain a significant decrease in the volume of the hippocampus and the white matter in the cerebellum, which are in fact the places that we know and we would expect are more sensitive to the hypoxia, that means the low oxygen produced by these toxic drugs like fentanyl and carfentanil, that they produce an immediate respiratory depression, no flow of oxygen to the brain. And this is important because that allows us to establish the continuity of brain damage that starts happening with an overdose, even if it's not registered by the clinician and written up in the medical record. So this is the picture of what happened in BC in the past 10 years, 250,000 overdose episodes that happened to about 100,000 people. You can see here year by year and the totals here below. That happened to about 100,000 people and killed around 17,000 people. And so if now we put a magnifying glass on people with severe mental illness as a subset of the people in BC, here we have, I just kept the first and the last year, 2015 and 2024. And if we look at this, so for example here, we see 2% approximately, and this is using administrative data, around 2% have severe mental illness, stringently defined, psychotic disorders such as schizophrenia, bipolar spectrum, or psychotic depression, around 2%. But if we come to this column here that identifies what's called the incidence of overdose, meaning the people that have for the first time an overdose episode, what we see is that in fact 15% of the people that every year have an overdose come from the 2% of people who have severe mental illness. And if we now look at let's say the prevalence, meaning it doesn't matter if it's the first episode or a later episode, people who have an overdose each year, we see that around 35% of the people who have an overdose come from the 2% of the population that have severe mental illness. And in fact, if we look at the people who die every year of an overdose, we can see that around 45% of people who die of an overdose come from the 2% of people with severe mental illness. And indeed, if we now focus on all the burden of overdose in the past 10 years in BC, more than 50% of the overdoses that happen in 10 years in British Columbia happen to people with severe mental illness. So this is extremely painful for very various reasons. The main one is that these are your family members, but the other one is that this has been happening for 10 years. And despite this, and of course it hadn't been analyzed because of various reasons that I may discuss later, but it is something that we can act upon because it's a small population that we can treat well and prevent this from happening. Okay, oh, right. So if you look here on the right, famously, the death rate of opioid overdose in BC is 4 per 10,000 individuals, or frequently 40 per 100,000 people. But that only obscures the fact that it is 900 per 100,000 people in people with severe mental illness, or 90 per 10,000 people. So completely, it's an epidemic that is happening mostly to people with severe mental illness, or those are the ones that suffer the most, the consequences. And this is additional data. I don't want to belabor the point, but around 7,600 people of the ones that died of an overdose already had acquired brain injury in their medical record, so very severe. And if we look here, this is a curve that looks at different age groups, 18 and younger, minors, and then each other age group. And what we see here, we focus on children and youth, which is particularly important for me at this point because it's the current area of my focus, because all of this can be prevented. Not the severe mental illness, as you know, which is mostly genetic, but the acquired brain injury can definitely be prevented. And a child who is of the ones who died of an overdose in BC, after getting the diagnosis of acquired brain injury, had about 7 years in average to live, or 5 years to live if the diagnosis was of anoxic brain injury, which is the one produced by these drugs. So in 10 years, the prevalence of severe mental illness or acquired brain injury in people who died of an overdose went from 30 and 45% respectively to 55%. So now people who die of an overdose have 55% of acquired brain injury and 45% of severe mental illness. Around more than 20% die within the first year of acquired brain injury diagnosis, and then about 15 die every year. Minors die an average of 7 years later, and so on and so forth. It gets worse, and people 65 and older die within the year that they got the acquired brain injury. Now, the important thing is that not everyone dies after an overdose. There's things that we can do. And this is a study that we conducted where we followed every person, thus 100,000 people in BC that had an overdose in the past 10 years. We started looking at their medical record when they got their first overdose, so these are incident cases, and we followed them up for 2 years and looked at what happened in terms of, did they have another overdose? Did they have acquired brain injury? Did they die of an overdose? And we looked at the transition probabilities. And if you look at this 4 ovals, what you can see is non-lethal overdose. These are 4 health states that we looked at in every British Columbian that had an overdose at any point in time in the past 10 years. And so we looked at non-lethal overdose, no overdose, staying free of an overdose for a year, getting acquired brain injury, or dying of an overdose. And what we see is that after having a first non-lethal overdose, someone in BC has 14% chance of the following year having another overdose. They have about 4% chance of having acquired brain injury, and this is newer data that I added more recently. 4% chance of having acquired brain injury, 2.6% chance of dying of an overdose, but about 80% chance of staying free of an overdose for another year. And that is so important because if they stay free of an overdose for a year, then they have 94% chance of staying free of an overdose for a second year. And then their likelihood of having brain injuries, etc., decreases. And if we look at people with severe mental illness, again, the same model, and this is very robust data, right? This is 24 months following up 100,000 people. So these are 2.4 million person months for everyone who had an overdose. And this is focused on the people with severe mental illness. As you can see, the outcomes are worse always, right? People with severe mental illness that have an overdose have 27% chance of having another overdose the following year, have 7.4 chance of having acquired brain injury the following year, and almost 4% chance of dying of an overdose the following year, and only 60% chance of staying free of an overdose the following year. So this explains why the burden is disproportionately happening to people with severe mental illness. And what we want to do is to interrupt those vicious circle by which people get more overdoses, more acquired brain injury, and therefore their cognitive impairment and their ability to be treated decreases dramatically. Okay, so in that context is that the Office of the Chief Scientific Advisor for Psychiatry was created in June 2024. And it was a very unique thing because it is an independent scientific office that my office, one of the things that was important for me was that it doesn't depend on any other government office, ministries or others. It doesn't depend on any political party or anything like that. I have access to province-wide data by delegation of Section 10 of the Ministry of Health Act, so I can compel the data. In BC, it's very frequent that data, even though it's from the public and should belong to the public, is guarded by the different groups and the different health authorities and the different everyone for various reasons. And there's layers and layers of bureaucracy that one has to go through to analyze this anonymized data. And so it's very difficult to get the full picture that we now have. I have a small team with a limited budget to do an analysis and operations. And then the Premier landed on a model of real-time recommendation implementation by which we meet regularly with the Premier and the ministries, initially the ministries of health and mental health and addiction, and the head of the public service and other key people in government, initially every 2 weeks and now every month. And they implement. Then I rely on the ADMs and ministers to implement these recommendations. I made my initial recommendations in September of last year, not of this year, of last year. And what were the goals? The long-term impact is to improve outcomes for people with or at risk of mental illness, substance use disorders, acquired brain injury, improve outcomes for families and communities. How? By increasing the quantity and quality of services, the integration of mental health and substance use services, which are now siloed, and the use of the Mental Health Act as a therapeutic tool. These are the 9 recommendations that I've been working on with different levels of success and let's say impact, because as I said, I rely on other arms of government for implementation. And so the first one is the centralized access and analysis of all the data that exists provincially. And this has been very, very successful in the sense that I have been able to get access to all the data sets that I've asked. All the government agencies have been extremely helpful with this, with some sometimes I had to formally request it and so on, but this has been very good. The clarification of the applicability of the Mental Health Act to people with substance use disorders, this has been quite good. So one of the confusions that I mentioned in the beginning was that advocates and some of my colleagues, unfortunately, had convinced the whole health system that you couldn't use the Mental Health Act for people with severe substance use disorder. And the problem was that that meant that if someone with schizophrenia had also a very prominent substance use disorder, they were not properly treated. They were just stabilized when they were intoxicated and put out the door and not treated for their severe mental illness. That's one of the problems. And then there are other problems that we can go into. So I released a guidance, which is the official policy of the government, in March of 2025 that explains when and how to use the Mental Health Act to provide involuntary life-saving treatment for people who are unable to engage voluntarily. And that is very well defined in the Mental Health Act. And of course, there are risks because we always value the right to liberty very highly. And so when it cannot be exercised because someone is mentally impaired, we need to treat so that the person can exercise the right to liberty again. And that is what I clarified. And now I have ready a similar document for the treatment of children and youth under the Mental Health Act, even if they disagree. And it's slightly different than for adults because there's more probability, there's more possibilities to intervene. We can intervene even if the child does not want at the request of the parent. We can admit a child under 16 and provide treatment at the request of the parent. This is not done in BC until this next Monday, when the official policy becomes official. because again, the same advocates, the same, unfortunately, sometimes colleagues had convinced the whole province that you had to treat any kid that told you, no, I don't want treatment and don't tell my parents, like a mature minor, which is preposterous. And we wouldn't do that with any other illness. If we have a kid who is confused because of hyperglycemia and shows up at the ED and says, no, doctor, don't give me insulin because I don't want needles, I'm traumatized or whatever, we don't give that kid a bus pass to go to the bakery and buy more cake. And unfortunately, we do that with kids that are recovering from an overdose and they get a bus pass to the downtown east side. So that won't happen anymore. That's my goal. It will be very difficult because change is very difficult in the medical profession, but it will happen eventually. And I'm working to desegregate mental health and substance use services. Again, as I said, unfortunately now, the addiction, the withdrawal beds that would help these patients, sorry, that's my dog whining. Unfortunately, they are not prepared to treat people when they became agitated, when they become psychotic, and in fact, they reject them outright because they have a process of admission by which our patients have to call, respond to a bunch of questions that they sometimes are unable to do, et cetera, et cetera. So we're working closely with the BCCSU and the Road to Recovery to integrate psychiatrists in the withdrawal beds across BC. It's going to be, again, long and complex process, but everyone now at least understands that they have to do it. And then streamlining access to some life-saving pharmacotherapies like clozapine through the development of a protocol of point-of-care testing, which with a pinprick, we will be able to follow up or ACT assertive community treatment patients. I didn't mention, I'm an assertive community treatment psychiatrist in BC. And I'm going to say a little bit about assertive community treatment later. Access to depot buprenorphine. Depot buprenorphine is an injection of an opioid agonist that you can give to a person, and that lasts a month, and that will prevent that person from overdosing. And that we will be able to, and we are able to do, and we should have always been able to do this as part of psychiatric treatment under the Mental Health Act. But again, unfortunately, same folks had convinced everyone that we couldn't do it, but now it's official policy that we can. We're addressing incentives and licensing requirements to expand the human human resources supply and developing a new contractual framework for ACT psychiatrists. We have created approved homes where something that could be created could always be created. Since the Mental Health Act existed here in BC, they were there, but they were never created because approved home is a home in the community where people can be mandated to live involuntarily under Section 22 of the Mental Health Act. And again, people, for some reason, believe that preventing this thing from happening was a good idea. And so these patients were cooped up in a fourth floor of a hospital, pacing the hallways for years on end. They were clinically ready to go, but too disturbed to be discharged anywhere because they would become homeless and die. And since these homes were not created because of the opposition of anything that had an involuntary ring to it, these persons didn't get humane, effective care. And now we've created 2 of them in Maple Ridge, and we hope to create more in other sites as we continue to expand services. Another incredible thing that had happened was that many of our patients wind up in corrections on remand because of theft, episodes of aggression, and many other things that happen when someone is agitated in a manic state or because of crystal meth or because of psychosis, and they land in jail. And the Mental Health Act did not allow for involuntary treatment in the prison, and so the patient was certified, and then they had to wait for a bed in the forensic hospital for a month in seclusion, banging their heads against the acquired brain injury being produced unnecessarily. Well, we designated 1 unit in Surrey pretrial as a mental health unit, and so now they get that treatment in the moment when they need it, and this has had a transformational effect on the prison population, not only of that unit, because people are brought from the general unit, the general prison population, to that unit and given the depot antipsychotic in the moment, but also the rest of the prison population now comply with the medical indications much quicker because they know that eventually, if they continue refusing, they will be transferred and receive it in the new unit. And then now we're expanding that to other units. We're expanding also beds across the continuum of care. We're doing something called needs-based planning, which is estimating the number of beds that are missing from the system at hospitals and in housing, which is a very large amount, and we're progressing very slowly. But surely we have identified 200 new beds, tertiary beds, in Prince George and Surrey. There's 160 confirmed, plus the ones in correction, plus the ones in approved homes, 200. And now I'm going to travel to identify and look at the feasibility of a couple more sites in the island and in interior health. And I hear that these are the first tertiary units that are going to be created since 1980 something or 90 something, other than Redfish, which is a very specific type. So that is happening, but we need a lot more. And then the creation of ACT, the expansion of assertive community treatment. Again, needs-based planning is underway. We had yesterday a conference, the International Conference of Assertive Community Treatment, which we hosted here virtually in BC, 400 participants. The Premier gave the opening remarks. The Minister joined us and endorsed this strategy again. And we have created a new specialized ACT team for the Downtown East Side to treat the repeat violent offenders, which are unfortunately many of our patients. And then the several partnerships are being created with VCH, the police, Crown Council, et cetera, et cetera. So those are the 9 recommendations that I'm working in with various levels of success, some more than others, but I continue to work on them. And I need very much the support and the efforts of family members, because you are the ones that know why these things are so important and can help us fine-tune whatever we don't get right. And you know, these are very complex times in the sense that there are constantly attempts to undermine these advances, as we've had many situations recently that have thankfully resulted in a successful re-endorsement of this strategy by the Premier, the Minister, etc. But you know, we need for sure this to be disseminated and well known. And again, that's my office, and the data was obtained from the Emergency Services, Coroner Services, Ministry of Health, in a PANDA platform and the Health Data platform. And as I said, the Hotel Tandem study, which was a landmark study, allowed for this. Okay, so I spoke for a long enough time, and I'm happy to take questions or comments.
So Marvin, over to you to ask the questions.
Okay, there are a few questions in the chat. I'm just trying to get at them. Okay. I'll start with one of my own. You talked about housing, and you talked about people with severe mental illness, with addictions, with acquired brain injury, and the overlap. But a lot of these people need supportive housing. And the policy in Ontario seems to be, and I've been very immersed in this, writing about it, you take a building with apartments and you fill it with people, some of whom have severe mental illness, some have substance abuse, some have both, some are there because they've just been discharged from jail, some from encampment.
The continuum of care for inpatient and housing services, because for very severely affected patients, there's no real discontinuity between inpatient treatments and housing, as we see, for example, with the approved homes, which have very intense of how it should look like. So if you're seeing here, sorry, just a second. That's not the one. anyhow, you're seeing it here, right? It's not,
Right, I am seeing it, yeah.
it's not the right one, but so basically you have the hospital at the peak of the complexity. Then you have high intensity housing, and this take many forms. For example, approved homes. Approved home is a secure house in the community with a fence that people cannot leave unless they are in their in a state of behavioral baseline that allows for that, and then they can be stepped down to residential, for example, care, or to specialized family care homes, which are a model that has been proposed, for example, by the BC Schizophrenia Society. And then you have assisted living, support, and recovery. And some of this, for example, here in moderate intensity, would require that people don't consume drugs in that place. For example, there should be options for all of these needs. Some people need housing first, meaning that people should not be left without a home because they are not at a point of abstaining from drugs. True, they should have a home, but that doesn't mean that there shouldn't be a home where people are required not to use drugs. So both things should exist. And the problem is that, as you point out, this nuanced approach has not been undertaken by government. What we have is a fragmented approach where, here in BC, for example, BC Housing manages one waiting list. Health Authority manages another waiting list. This organization provides this type of care, and they set their own intake criteria, and so on and so forth. It is chaos. And so the recommendation is that we need a unified system, continuum of housing and hospital services of need, and people are sent to the hospital or housing level that they need. We are underbedded. Very preliminary results tell me that we are underbedded by about a third if we consider all the hospital beds and the housing beds. So we need an enormous shift in strategy if we're ever going to produce the third of beds that we need here in BC. And I don't know how it is in Ontario, and I'm sure it's not as bad in the sense that here the crisis with the toxicity of the drug is something no one has seen in the world, but it's very bad in Ontario because your Mental Health Act is pretty worse than ours, in the sense that you can contain someone, but you cannot treat them, and they have to wait for some type of process, etc. So that's what should be happening: a unified, centralized intake and referral process for housing.
Okay, thank you. That treatment options. Which audiences do you feel are the best focus for our limited taxpayer lobby, pharmaceutical lobby?
Well, sorry, I see that: journalist, government official, ombudsman, selected politician.
Okay.
So what I've seen is that it's not by coincidence that I was asked to help the government. I've been saying the same thing for a few years. Basically, society changed. Society doesn't buy anymore the stuff that had been sold for so many years. And so I think, and politicians, some politicians have been courageous enough to do something. And I have to say that when I agreed to do this job, I didn't think it would be, I didn't think many things, but one of the things I didn't think was that the support from the Premier would be as unwavering as it has been. And so, staying with media focus on this, not giving up on the discussion, not accepting this notions that involuntary treatment has anything to do with control, with punishment, all of that stuff has taken hold of many people, but that's just because we've been not doing a good job of explaining what we've always known, that the medical rationale for the delivery of involuntary care for someone who is impaired happens in every reasonable society with a functioning health system. And the most frequent reasons are not in hospitals, for example, are not mental disorders. People with confusion or delirium due to sepsis, due to a post-surgical state, due to metabolic imbalance, due to concussion and loss of consciousness, when they are confused and they want to go home, we don't let them. And we use the Healthcare Consent Act when it's not a mental disorder, and we use the Mental Health Act when it's a mental disorder, because the Mental Health Act provides a number of very important safeguards to the right to liberty and to the right of the person, like the review panels, like now the independent rights advisors, and many, many forms and things that we have to do, because it's no minor thing to involuntarily admit someone. But it has nothing to do with what's done in other countries where, and I know those countries where people are tied to sheds or to trees or to wherever. That's where the main concerns should be about people being mistreated. Here in Canada, psychiatrists are not out there. We're not out there to harm people. We're out there to take care of people like any other physician. And so the use of the Mental Health Act is a life-saving therapeutic tool. It's not a coercive tool. It's not a evil thing. And that discussion, we have to give it every time we hear this conflation of medically indicated access to care versus this sort of ghost of control or whatever. So that's my keeping the pressure on the public, on elected officials, on the press, so that everyone knows that it's a different environment and people want to help people in need.
Okay, one last question, unless you're willing to continue, but anosognosia is an issue that families have. And the question was, how could we support the wider use of screening for lack of insight?
What I would say is that any psychiatrist understands very, very profoundly the issues that stem from anosognosia. Again, I don't want to generalize. It may be that in some situations, some specific situations, it's a problem. I think the main problem is that when mental illness is framed instead of as a mental disorder, when it is framed more as a lifestyle choice or as a different thing, then the problem of anosognosia gets turned into an issue of liberty and choice and so on and so forth. So I'm always aware, and any physician should always be aware of anosognosia. But you're right, maybe because our system relies so much on non-specialists to provide part of the care, meaning GPs who shoulder a very large fraction of the burden of mental disorders in Canada, maybe they can benefit from screening tools that very clearly let them know when the person in front of them is unable to understand that they are suffering from a given disorder. So I take your point. So I think maybe the dissemination of anosognosia among non-specialists or among the other disciplines that are necessary in the healthcare team could be a way also to the need to provide care even at points when the person is unable to understand that requirement.
Okay, well, there are a number of other questions, but it's getting a bit late, so particularly in the eastern part of the country. So I think somebody was going to thank you for your presentation today. Kathy?
You're muted, Kathy, but other people should be muting themselves.
Yeah,
I'm sorry that there's other questions that could not be answered, and I sort of feel the frustration of these people that did ask the questions. However, I'd really like to thank you so much, Dr. Vigo. I mean, I'm quite fascinated by this whole topic, and we'd like to clone you and have you come to Ontario. And we would, you know, I tell you, I don't know. Anyway, you've given me some tips, so and I've learned a lot, and I really do appreciate your time, and I'm sure everybody here appreciates your time. And
I mean, I don't mind answering a couple of quick questions,
Okay.
but I don't want to. If people want to disconnect because they are in the east,
No.
they can do it. I won't feel bad. I do sincerely appreciate the opportunity of exchanging with families, because I know how much we need you, the families, to treat these patients. So
yeah. So Marvin, can we have a question from somebody who has a loved one with a concurrent disorder? Would that be helpful, do you feel?
I'm trying to see if there is one.
Michelle Cofoot or Lisa Cofoot on her behalf, perhaps you would like to ask a question?
So I see a question here that says, how can we reverse some of the harm reduction policy when it comes to someone living with a concurrent disorder? If I understand that correctly, the question here is about broadly harm reduction and concurrent disorder. So harm reduction is an example of a type of intervention that can be extremely useful and life-saving when used well, and can be devastating and terribly harmful. Because of course, if you have someone with only, let's say, an opioid use disorder, and the person injects heroin, and the person has decided that, and et cetera, and is not willing to engage in care, okay, providing needles, providing safe injections, et cetera, very important. If you have someone with schizophrenia who is using fentanyl to counter some delusions or some hallucinations, etc., and instead of providing the treatment they need for their delusions and to prevent the serious physical deterioration that would result from the continued exposure to toxic drugs, instead of that, you provide harm reduction supplies in a non-therapeutic environment. Needless to say, if you provide what's called safe supply, which is the biggest misnomer in the history of policy, then what you have is a system that, because it misapplies something that can be very valuable for some patients to patients that can be really hurt by that.